Okay, so normally there are kind of three ways the body controls cell growth, right? We don't want our cells, in fact, that's basically what cancer is, when your cells kind of go crazy and start growing all over the place. So we have these three ways of controlling that. We do that through proliferation, right? And proliferation is just the process of cells dividing and multiplying. Just if you remember from high school biology, it's just that mitosis, right? And then cell differentiation is the second aspect, and that's the part where the cells become specialized. So they become the cell they're going to be. So when they begin, they're basically stem cells. They're cells that have very little characteristic. They're just proliferating and proliferating and proliferating, and then eventually, as they keep going through those cell divisions, they become more and more specific to a specialization, and then they mature fully into whatever they're going to be. So when we talk about colon cancer, we're going to talk about how they mature into enterocytes or goblet cells, and they just become what they're going to be. And at that point, they stop dividing. They're no longer able to divide. So it's a very, very kind of orderly process, right? And then the third thing that controls the cells would be your apoptosis, which is just normal cell death. It's when the cells, they get old and they die. And we want that, because if we don't have that happening, we're going to have new cells growing on top of old cells, and that's going to be a problem. So between those three things, we can control the population of the cells in any tissue, right? So when that goes wrong, there's some kind of disordered cell differentiation or growth, we end up with this kind of new growth called a neoplasm. And literally, you guys from the other class know that I love to break down words, and I find it's so much easier to get through a test if you don't have to memorize a million different terms. So when you see the word plasm on the end of a word, we're talking about a growth, some kind of growth. And then in this case, if we're talking about a neoplasm, we're talking about a new growth, right? And so that's basically all that cancer is. Usually they will continue to grow, you know, and continue to, there's just no regulatory control on it. And so it will just continue to grow. And let's see what we've got here. I probably went through. Okay, so yeah, I don't, you guys can read through these slides on your own. And you know that most of the time these things don't show up on the tests, right? So I would definitely like have it in the back of your mind, but you know, you can read them. Okay, so when cells are under stress, they do one of three things. They can atrophy, hypertrophy, or become hyperplasic or hyperplasia. So atrophy is shrinking kind of. So again, trophy, anytime you see trophy, we're also talking about a growth. Unfortunately, in medical language, there's a little bit of that where you might see two kind of suffixes or prefixes that mean the same thing. That's fine. You know trophy, and you know plasia is going to mean some kind of growth, right? And you know if you put an A in front of that, it's working against it. So atrophy is actually the opposite of growth, which is shrinking. Hypertrophy would be exactly what it sounds like. Too much growth. You're increasing. It's abnormally increasing. And then hyperplasia, again, this one is more like, so hypertrophy, the increase is more like the cell itself is growing. The cell itself is getting bigger. And then hyperplasia is more like it's actually proliferating, right? So it's actually creating new cells. Hopefully that makes sense. By the way, guys, if you have questions, just throw them into the chat. And I usually hear the bang and I can come back. I can't see the chat right now, but I can flip over if I need to. So if that stress goes on, the time for goes on and on and on, and it's not corrected, and then we end up with this kind of regression of maturity. So this anaplasia, meaning that differentiation that they once had, they became goblet cells or they became enterocytes. They start to lose that. They aren't being differentiated. There's less specialization, and they kind of return to those immature states. And then remember I said when they get to the mature state, they can't proliferate anymore. But if they I always imagine it like they're melting down. They melt down to an anaplasia, to a state where they're just immature again, they actually can start dividing again. And those like anaplastic cancers are really aggressive. They're sensitive to chemo, so that's really, really good. But they are really, if you put small cell, it's on the slide, small cell lung carcinoma really proliferates really, really rapidly. But we can treat with radiation and chemo and hopefully prolong life and relieve some of the symptoms, right? Okay, so metaplasia and dysplasia. I would recommend making sure you understand all of these words. So they will probably show up in a test, and you don't want to lose marks just because you didn't spend the time to understand, what something means. So metaplasia is basically when you replace one kind of differentiated cell with another kind. So exactly, a squamous cell turns into a columnar cell. It's almost like it can happen almost like losing your baby teeth, like the squamous cells developing beneath the columnar epithelium, and then it proliferates and differentiates into a squamous or columnar, the squamous, and the columnar dies off. And then all that's left is a layer of squamous cells, right? So if you kind of imagine it like that, it helps me. And then something happens with this. I don't have a pointer. Hopefully you can see that. This cell-to-cell contact inhibition. So cell-to-cell contact is this a mechanism that stops cells from growing or proliferating where they shouldn't. And they basically, once they come into contact with another cell, they stop growing. So that's really important, right? We need that. And if that stops, if dysplasia, if it's damaged, we're going to end up with cells growing up over top of each other and all over the place. Really, dysplasia you'll see way more often, the word dysplasia, like this idea that it's just this very abnormal cell growth. It's a bit more of a broad term. So, but also this is you'll see this term a lot, this carcinoma in situ, and it's really just when you see it, it's referring to this state right here where you have dysplasia. I have a picture of it later, but you have dysplasia, but it's not yet turned into cancer. It's just this really abnormal growth in your body. And yeah, you can catch it early. If you catch it when you have this dysplastic growth, then you're good to go. It's not going to turn into a huge new growth. And that's why they do pap smears so often, so often. So I'll let you guys, go through things like statistics, and this is just kind of showing you the difference between the more aggressive cancers and the more survivable ones. There's really not a big difference in risk between men and women. It's negligible. Men are slightly higher. And the most common cancers that you're going to see are going to be lung, breast, colorectal, and prostate. The incidences of these have actually gone up in the last like 10 or 15 years, but I think that they think it's related more to the fact that we're detecting them a lot earlier, so not necessarily that the cancer is actually getting more common. So I don't know why we had two of these. Oops, sorry. But we now understand this, right? Cancer is basically just a tissue overgrowth that isn't controlled by the regular rules set up in the body. There's a fine line between the repair of injured cells or old cells, and this neoplasia that's out of control and serves no purpose whatsoever. Just checking. I thought I heard a bing. Nope, good. Okay. So how does that happen? So usually during the proliferation stage, there's normally some order to how the cells are proliferating. Like with epithelial cells, there's that contact, like what we talked about earlier, that contact inhibition keeps them from growing over each other. When that contact inhibition is lost, again, they're not going to know where to stop, and they're just going to divide indiscriminately. What's on here? Okay, so the cell cycle. I don't think you guys need to go into, I mean, correct me if I'm wrong. Oh, there was no video, so you don't really know, do you? Okay, let's just basics. We'll go over the basics. So there's the cell cycle is the way the cells divide. Some of you will remember this. Some of you probably have biology degrees and you're going to laugh at the way I explain this, and that's fine. I'm going to explain it the way nurses need to know it really quickly. There's these two major phases throughout this, from the stem cell to becoming splitting into two daughter cells. There's phases within phases, but we're not going to go too crazy. So the first part here, I just want to go like here, we're talking, is called interphase. So it's the cells are growing and they're copying their DNA. They're not splitting, right? And then the other kind of major phase would be your mitotic phase or your mitosis. And that's when the cells completely separate into two separate cells or two daughter cells. And then those daughter cells sometimes will start the cycle all over again, right? And they just keep repeating and repeating and repeating. So really interphase is the cell has just formed. It might be it's a daughter cell itself, right? It has just formed and it has to prepare itself to divide in the future. So interphase is kind of that time when we're sitting and we're getting ready to start mitosis, sorry. And some cells will actually stay in that. We'll talk about that a little bit later. But if you look here, you've got these kind of like G phases, your G1 phase, G2 phase. So in the G1 phase, the cell's growing bigger, it's copying some organelles, might form some molecules that it's going to need for mitosis. And then we have the S phase. The S phase is when the cells, this is an important phase because this is when the cell is synthesizing a copy of DNA inside the nucleus, right? And remember the DNA is in chromosomes inside the nucleus. So this is that phase. And in fact, this is often the phase where cancers will start. So, and then it's probably doing some other things in there, but we'll talk about that later. That's the most important thing. And then we have this G2 phase. Again, cells are growing more. They're synthesizing proteins and organelles. They're starting to reorganize the contents to prepare for mitosis. And then that G2 phase ends when mitosis begins. And so those three phases, the G1, sorry, let me start here. The G1, the S, and the G2 are all part of the interphase, like the overall interphase, okay? And then we have mitosis, and mitosis is when we're actually starting to divide the cell. So the cell divides, it copies its own DNA, like it's a really complicated procedure where the DNA unwinds, it kind of unzips down the middle and then replicates. We're not going to go through all of that. And but it copies the DNA and the cytoplasm and makes two new cells. There's 4 phases if you remember, and we're not going to go through them, and you don't have to know them. But you remember that from high school probably, that prophase, metaphase, anaphase, and telophase. And basically what's happening is inside the nucleus, the DNA is condensing, it's becoming invisible chromosomes. There's this microtubule that forms into this mitotic spindle, and then it pulls the nucleus apart and you end up with 2 nuclei, then you end up, and it just keeps pulling and it does a bunch of different things and you end up with 2 different cells. So this is where that's happening, and that's important. We need to know that for where we're going in the rest of the slides. And then at that point, the cells will differentiate or begin to differentiate depending on the type of stem cell we're talking about. So for example, blood cells have a specific stem cell that will then differentiate into red blood cells or white blood cells, macrophages, and it goes on and on. But it will decide what, I mean, it doesn't decide. It's going to be what it's going to be, maybe a fat cell, a muscle cell, whatever. And then, let me see here. So if it's the type of cell that divides rapidly, it'll just go right back into interphase really, really quickly. Embryonic cells are like that. They just flip through really fast. And then tumor cells, unfortunately, often are like that as well. Some of them will go into that next interphase very slowly. Some of them don't go at all. They just sit in, and they call it a G0 phase. They just sit there. It's not actively preparing to divide. It's just doing its job. Like it's just being a red blood cell, or it's just being a neuron. It's not getting ready to divide. And then it may or may not get the signal at some point to divide. And then it will. I think I threw in, so like this, I threw in Darla. But again, it's not something you need to know. It's just kind of giving you an idea of like certain things are going to, certain cells are going to go through that cycle a lot faster. And that does come into play a little bit later when we talk about chemotherapy. So your head hair is definitely, the cells are, the cycle goes fairly quick. But then if you look over here at the neurons, every 20 to 30 years you get that proliferation happening, right? So it's just every cell in the body is going to go through that at a different kind of rate. Okay, so I just want to make sure before we go on. Okay. Oops. So this is really just summing up what we just talked about. I don't think there's anything on this slide that we haven't said. Once it's mutated, okay, we can talk about that. Sorry. Just give me 1 sec. I've got a issue over here. Okay. We will talk a little bit more about, okay, so something happens, there's a defect, usually in that S phase, like we were looking at earlier. It's going to happen up in here where, remember I said the DNA is replicating? There's some kind of loss of control and the proliferate, and you end up with these mutated stem cells. And then once that cell, even if it's one cell, once one cell has mutated, it has a couple of options. It has a couple of things that it can do. It can die because it's damaged through apoptosis. I really don't like calling it cellular suicide, but through apoptosis, it can die. We'll look at it like that. It can recognize the damage and repair itself, or it can survive. And when it survives, it will pass on the damage if it proliferates. So if it becomes, goes back into interphase, or starts to create daughter cells, then those daughter cells may or may not also have that mutation in them. And that's kind of where all of those cells that are mutated, we wouldn't call that cancer at that point, but they have the potential to become malignant. Okay, these are things that we need to, this is something you need to really understand. So proto-oncogenes, so during the cell cycle, there are these proteins that are involved in regulating how and when the cycle moves forward. That you have positive cell regulators and you have negative cell regulators. And the positive cell regulators are the ones that work to advance the cell to the next phase. They're accelerators. So if you're thinking about, driving a car, whatever, it's the thing that makes the car accelerate, right? And then the negative cell regulator, you can probably guess, would be the brakes. It's the thing that stops, it blocks the cycle of progression until, not in a bad way, but just until certain events have occurred. So between those two things are working together and against each other to try to make sure that everything that needs to get done gets done before we turn into a fully formed daughter cell. So let's talk about proto-oncogenes first. Proto-oncogenes are normal genes that are just any gene that when it's mutated in a certain way, again, it's affected in that S phase, right? It becomes an oncogene. And an oncogene is a gene that codes for cancerous growth. So the oncogene, this is definitely a word you want to remember. That is this whole thing we've been talking about, how the cells are splitting and how the cells are, if a mutated one passes on the mutation to its daughter cells, that mutated one, that's become your oncogene now. So it might have started as a perfectly normal cell, but it's become an oncogene because it's mutated. So we don't really know how that happens, where the oncogene mutation always comes from. And again, once that happens, it can die. It can recognize the damage and repair itself, or it can go on and pass that damage to the daughter cells. Now, development of remember I said like it has the potential to become malignant. So development of a cancerous tumor usually requires more than one mutated regulating gene. So more than one of those positive or negative regulators are usually affected. So I think that makes sense, right? Does anyone have any questions about that? It's just really important concept. So at that point, the person isn't necessarily harmed, right? They're just gonna, everything is fine. It's just this one or two cells that have mutated. So if you think about it, remember we talked about the positive and negative regulators. So think about what would happen if a gene mutation happened in one of those positive regulators, and it made it kind of go into hyperdrive. So it would be super accelerated, right? The cells would be pushed past checkpoints that they're supposed to hit before they move on to the next step. It would push everything to going super, super fast, and then the daughter cells would be damaged. And again, if that daughter cell is too damaged, then to undergo further like cell division, then it's fine. But if that daughter cell is able to divide, then you're going to have all these new generations and generations of mutated cells. And then those cells that are mutated, once they're mutated once, they will often pick up like more mutations. In this case, so we're gonna, I think in your slides she talks about one of the positive ones, CDK. So let's just talk about CDK. It's just a protein. It's a positive regulator, and that's if that gene. Once that gene has been affected, it becomes an oncogene, right? So there's lots of, let's look at this. So yeah, this is just showing you like, the pyramid effect when you have one cell that then splits into two. And if you look here, like if you remember how genetics work, right? You've got actually a carrier guy here, right? That doesn't necessarily have the mutated gene, but he still passed it on to the daughter cells, right? This is really just visuals of what we've been talking about. Sorry, if you like the visuals, I'll stay on them for a second. Okay, and summarize, this really just says everything that I just said, so I'm not gonna go through it again. This is just showing you, again, it's just a visual of what we've been talking about. You've got you know, this is the normal gene sequence, everything is happy, and then all of a sudden you end up with one gene. So you know that a gene is kind of a section of this DNA, right? Oh, a section of the DNA, and that section becomes mutated, and now it becomes an oncogene. So a tumor, tumor suppressor genes are, I mean, they're exactly what they sound like. They suppress tumors. So it's actually, we talked about positive and negative regulators. It's a negative regulator. It's a negative regulator protein that prevents the cell from dividing uncontrollably or haphazardly. It slows down cell division. It repairs your DNA mistakes, and then it will trigger apoptosis when it's necessary. So if there's a cell with a mutated negative regulator, then it's unable to do its job, right? It's unable to put a stop to the cell cycle if there's a problem. It can't stop and repair a mistake. It can't slow down cell division to make sure a job gets done. So it's going to end up, and this is where, because your tumor suppressor genes, one of its jobs is to repair mistakes in the DNA. Because now that's mutated, you're going to have even further errors in the cell. There's nothing there to fix those errors anymore. And then again, it's going to trigger, it may divide, and you'd have more and more and more of that happening. And so remember I said that it often takes more than one damaged gene to trigger like a cancerous tumor. So if you had a negative and a positive, you know, the more genes that are affected, the more that push and pull between the positive and the negative regulators is not working. Sorry, I didn't read this, but that's pretty much what we're talking about. Cellular experience. Yes. I'm just sorry. I'm just explaining it instead of reading it. I hope that's okay. So again, same thing, just a picture, just showing you. You guys can look at that when you want to. So okay, let's talk about the difference between a benign and a malignant neoplasm. And remember, the neoplasm is we're past that phase where the cells have mutated, they've become dysplastic, like there's a dysplasia happening, and then that dysplasia grows and grows and grows, and now it becomes a neoplasm, which is basically a tumor. And so we want to find out, you always hear people talking about benign or malignant. Malignant is the bad one. If you have a hard time remembering, I always just think it's malignant is malicious. I know that's stupid, but whatever you need to do to get through. So malignant is the bad one. Benign is the, I mean, I wouldn't say good, because it's still a benign tumor is not great. It can still grow quite large, and you know, it can press on your, if you had one in the brain, it could press on important parts and stuff, right? So it's not necessarily good, but it's not as bad. So what's the difference? So usually they will be well differentiated, and what that means is when we take the cells out and we look at them under a microscope, if you look here at this top picture, you can see that you can actually see like the lines between the cells. You can see where one cell begins and one cell ends. It's not as good as it could be, but you can. And then if you look down here at the bottom picture, you're going to see something completely different. This is where they are poorly differentiated, meaning they're just, you can't even tell where one cell ends and one cell begins. They're all misshapen. They're all kind of splurring into each other. Yeah, so you can actually have, so for the purposes of this test, I guess we're just saying that benign is well differentiated and malignant is poorly differentiated, I guess. But you can actually have malignant tumors that are well differentiated and yeah. But you guys go by whatever's in the slides and the textbook, right? So they are encapsulated, meaning that they're enclosed. A benign neoplasm is encapsulated. It's enclosed in a capsule of connective tissue, so it's confined to a specific area. Then but a malignant one, is not encapsulated. So it's much more easy for it to kind of move around and grow, right? And then the benign neoplasm, it grows by expanding. So it's the tumor or the neoplasm itself is just going to get bigger and bigger and bigger, right? Whereas in a malignant, it will do that, plus it will infiltrate, meaning it will start to push through the boundaries between the tissues that are surrounding it. So, for example, in the colorectal cancer, if you have a neoplasm on the inner lining of I don't know, of the transverse colon, it will start to, when it infiltrates, it will start to push through the wall of the colon and start to grow on the outside, and then grow and grow, and it can spread to nearby organs as well, right? So it's not just getting bigger, it's actually spreading. And so that's obviously really, really dangerous, right? And then you have let me see. Okay, so benign neoplasms they look kind of a lot more like their parent cell. One of the things that malignant neoplasms have a lot of that benigns don't is vascularity. So they actually grow their own, just like when we talked about in stroke, we talked about how about angiogenesis, about how they grow their own like blood vessels. That actually happens around a tumor as well. And so you get a lot of them. So a tumor it can't grow past, I think, like a millimeter in diameter, so like the head of a pin. It can't grow any bigger than that without a blood supply. So even in a benign neoplasm, you have some blood supply, but a malignant neoplasm will have a lot. So marked vascularity, right? So that's a good thing this is a good slide to kind of remember the differences for a test. And of course, this slide too, because it says pretty much, let me see. Well circumcised, not circumcised. This just means that the margins around the tumor, so you can clearly see where the tumor ends and the rest of the tissue begins. But in a malignant tumor, you don't have good margins, meaning you can't tell where one ends and one begins. And you can imagine for surgery how that has ramifications for surgical procedures, right? Benign tumor is usually a tumor that can move around a little bit. So when you feel it from the outside, you can actually feel it kind of moving a little bit. And then the malignant tumor is the one that it doesn't move. It's stuck. It sticks to itself. It kind of sticks to where it is. Again, this one, the benign one, isn't going to outgrow that capsule. Remember, we said it was encapsulated. Malignant might have a capsule in the beginning, but it will outgrow that capsule. A benign tumor is not able to spread through the blood circulation or the lymph circulation, but a malignant one can. It can cause metastasis. And then a benign, this is one where, so for girls, when you sometimes kind of get a panic and think maybe you have a tumor or something, usually if you have like a mass in the breast, that increases with the menstrual cycle and then kind of shrinks down, that's something that's obeying your body's physiological kind of order. So in that way, that's a characteristic of a benign tumor, right? As opposed to in a malignant tumor, it's not going to do that. It's just going to stay there all the time. It's not going to react to hormones or anything else. So again, this is a really, really good slide. You want to make sure you know the difference. One moves around more than the other. One outgrows the capsule. One can metastasize, the other can't. Because you may have a question where it's like, you have a patient, they come in, they have a tumor on their breast, and what would indicate that the tumor is malignant or is benign, right? And then it gets bigger during their menstrual cycle or whatever. Sorry, I'll keep going here. I think I talked about. So all that here, I would think that, yeah, there's just these kind of 3 stages of development of cancer, the initiation, promotion, and progression. I think she talks about what the stages are somewhere down here. Yeah, okay. So initiation it's the thing that causes the mutation, right? It's the predisposing factor. So it might be cigarette smoke. It might be I don't know, like too many X-rays, I guess. It might be HPV. HPV would be a bacterial one, right? So there's different kinds of initiators. I just want to make sure. Oh, here. Okay. So again, this is repeating what we talked about. The cell can die, repair itself, or replicate. Generally, it's irreversible. But basically, the initiation is the thing that causes the mutation. Some things can be initiators or promoters, meaning that they do the second step as well. So, for example, cigarette smoke would be something that would initiate the cellular damage, but then would keep that going, right? If you didn't stop smoking, it would keep that. It would promote that. So there's different kinds of carcinogens. Carcinogens are things that initiate. So different carcinogens, you have chemical, you have radiation, you have viral or bacterial, and that's right there. That's the HPV. And then obviously genetics are going to play a huge role. It's really weird. The kind of tumor that my son had, they asked us to go and ask family members, and it turned out that 2 people on my mom's side had the exact same tumor. One passed away and the other didn't, but so it was just the strangest thing. I don't know, genetics always freak me out a little bit. And chemical, we're talking about things like asbestos, like radon. Smoking would be a chemical as well. Radiation would be like your CTs and X-rays, and probably there's a lot of other ways to get radiation. But I'm a nurse, so that's what I think of. And then, yeah, hepatitis, I guess, for viral and bacterial. But those are just some examples so you know that you can tell the difference, kind of. So then the second stage is this promotion. This is like the time period where the mutated cell, so it's been initiated, now it's proliferating, it's growing, and then while that's happening, there are promoting factors. For example, if you have a cancer that starts because of, let's say, asbestos, but on top of it, you know, you're obese and you live a sedentary lifestyle, those would be promoters, right? And again, with smoking, for example, smoking is going to be a promoter, and it can also be the thing that initiated. So, oh yeah. So if you have something that initiates and promotes, like smoking, we would call that a complete carcinogen. Right, remember that. Nutrition, high fat, obesity. Okay, we talked about all of that, right? Oops, sorry. And then the third stage is progression. This is where suddenly the tumor is growing and it's spreading and it's invading other areas. It's going to start getting, there's that blood supply, right? It's going to start getting more of a blood supply because it can't grow, it needs to grow. It's going to invade the surrounding tissues. It may or may not metastasize, and obviously it has escaped immune surveillance. This is just showing you, how, like, the angiogenesis, right? So you've got the couple of tumor cells here, there's blood flow around it but not to it, and then this would be the head of a pin. This would be very, very small, and then as it starts to get a hold of some more blood or blood supply, now you're going to see the tumor grow, right? And then more and more blood supply. This is, oops, angiogenesis. Just remember the word. That's the blood growing like that. The vessels growing, sorry. So this is just telling you how, I guess, how things metastasize. So they can grow, they can just grow where they are, or local extension. The tumor can, if it invades, right, that means it's growing through the structures around it, like I was talking about with the colorectal cancer. It can seed. So seeding is when so cancers will shed cells. They shed their cells, and so sometimes those shed cells can end up somewhere else in the body and can grow another tumor. And then the big way that they travel in metastases is through lymph and blood. And again, metastasis, I don't know if we defined it yet, but metastasis is what happens when you have a primary tumor that spreads to somewhere that is just completely different. So you have a primary tumor, you know, in the kidney, and then suddenly you have a secondary tumor in the lungs, right? That is it has metastasized. It's gone through the blood system, or the lymph system has traveled and metastasized somewhere else. And colorectal cancer, that usually happens in the liver. That's like the big kind of where it happens. It's just showing you nothing major. So again, the local seeding, they shed cells into spaces around the organs, especially in the peritoneal cavity. That's really common, especially with ovarian cancers. And then when that happens, the patient often has that ascites or a pleural effusion. And then obviously there's a high risk of seeding during surgery. There's actually, it's become a lot less risky now, but again, for the purposes of the test, this would be a high risk situation, right? Like a seeding during surgery. So in other words, if they go in, they do a biopsy, and they cut around, or they touch the tumor, it's more likely for those cells to shed off, right? Oh, okay. It's just showing you a picture. This is just literally like what we've been talking about, right? You've got, you know, a few malignant cells, now you've got more malignant cells, now you've got more, and then at the end here, this bottom one, you end up, this is, well, you've got dysplasia going on, and then the bottom, I guess, would be your neoplasia. Oh no, there's your neoplasia. So beginning, these are just dysplasia, maybe dysplasia, neoplasm, and then the bottom one is a neoplasm with, now it's gotten blood supply, and you can see it's traveling through the blood and going somewhere else. So that's metastasis. Again, I think we talked about this already, invading neighboring tissues. So I'm not going to go through this. It's not saying, I don't think it's saying anything new. It's just a picture of what we talked about. Obviously, cancer is dangerous for a number of reasons, right? It's going to travel in, travel through to other areas of the body. Let's just keep going. Corrupts the surrounding environment. Don't worry about trying to memorize like what it does to proteases. What does it do to cytokines? What does it do to fibroblasts? And just know that it's going to if you look at this mess, it's disrupting the entire matrix around it. So your body's around that's not going to respond to anything the way that it should. Okay, so how we classify cancers, there's a couple of different ways. And it can be a little bit confusing because you hear about it out in the world, and anyway, let's go through them so you don't mess this up on a test. Where should we? So yes, there's different kinds of cancer. So where the cancer is, right? Lung cancer, breast cancer, and if you look through this, all leukemias are cancers that are in the bloodstream. Lymphomas are cancers that are in the lymph nodes. Now, a sarcoma is a cancer that grows in the body's connective tissue, so fat, bone, muscle. And then a carcinoma is a cancer that grows in or around an organ, so your lungs, breast, colon, bladder, prostate. Okay, just kind of make sure you know the difference between a sarcoma and a carcinoma, and then everything else just kind of makes sense. So there's no words on this slide, but I'm guessing they're trying to show you what a biopsy is. So you can see the little needle there going into, little needle here going into the patient. They pull off a tiny little piece of the tumor. Sometimes they pull off the entire tumor. Sometimes they use a tiny little needle, sometimes a bigger one. But then they take that and they put it under a microscope, and they can see the cell structure. This is kind of how we end up grading and staging the cancer. They have to look at it under a microscope, and then they show kind of like a DNA results. This is kind of stuff we've talked about already, but a normal cell is, it's normal. And then you've got on the other side, so say you've pulled that biopsy and you're looking at it under a microscope. These are the things that you're looking for in the cells. They're large, they're shaped irregularly, they have different shaped nuclei, there's a variation in cell size and shape, and you saw that in the one slide that we looked at. It loses its specialized features, it's not differentiated anymore, it's disorganized, and again, that poorly defined boundary, we can't see where the tumor ends and the rest of the body begins. Okay. So when we talk about histological analysis or classification, this is the grading. So grading is talking about what the cells look like, this whole stuff over here that we were just looking at. So grading is telling you what the cells look like. So we grade depending on that. So if the cells are slightly different from normal, but they're still well differentiated, it's a grade 1. If the cells are more abnormal and they're a bit more differentiated, it's a grade 2. And then when they become very abnormal and poorly differentiated, it's a grade 3. And then a grade 4 is when the cells have basically gone back to their immature primitive state. They're undifferentiated, and we can't even figure out what kind of cell it is. Okay, so just remember that grading is about the cells. Oh, this is good. This is a little picture. This is a really good picture to show you the difference between well-differentiated cells and really poorly differentiated cells. So these cells, they look like epithelial cells. You can see each cell looks like a normal epithelial cell, and then you look over here and you can't even tell where one cell ends. And if anaplastic, again, remember what that means? It's gone back to its kind of primitive state, and it's no longer differentiated. It doesn't even look like what it's supposed to be. Oh, there we go. Okay, so then that was kind of grading. When we talk about staging, we're kind of talking about where the tumor is and how big it has gotten. So if you look here, there's better slides for this. I saw it later somewhere else, but let's go through this slide first. So remember we said cancer in situ it's just starting. We've got a few dysplastic cells, and then one would be a tumor, small tumor. It stayed where it started, hasn't gone anywhere. 2 would be now it started to grow, but it's still growing within the same organ or the same space. And then 3, we've got extensive local and regional spread, meaning it has invaded other tissues, but it hasn't metastasized yet. 4 would be when it does metastasize. And these should be, most of the time, they're graded in Roman numerals, just so you know. So like, if you see it on a test, it might look like a Roman numeral, but it's just still the classification. Okay, this TNM is really, this is part of this classification of where it is in the body, how big it is, not the grading, right? So, whoops, sorry. So they use this TNM classification. So I used to do medical transcription back in the day, way before I became a nurse. And I would always type up these cancer notes, and they would say, so-and-so, we saw so-and-so in the office today. She has, a T2, N2, M1, blah, blah, blah tumor. So this is what they were talking about. The T represents the size, the tumor size. The N is the spread, and then the M is whether or not it has metastasized. This is definitely a slide you want to make sure you know. So, a very small tumor is a T1, a 2 to 5 centimeters is a T2, and then a 5 centimeter is a T3. T4, now it's broken through, the skin, or they attach to the chest wall. That stinks. So really just, you don't have to memorize like numbers, just kind of know that like smaller, medium, large, and bigger than 5 centimeters is considered a fairly large tumor. I don't even know how big my son's was, but it was massive. They took it out and they showed it to me, and it was like if you put 2 of your hands together in fists, it was like that big. It was very large. I don't know how we didn't. Anyway, so okay, so your second now is talking about lymph node status. Has it spread to the lymph nodes? So no, it hasn't. It's a 0. If the lymph nodes around it are swollen, it's an N1. Oh, sorry, N2. I guess if you can, okay, sorry. It's an N1 if they're swollen. It's an N2 if they're swollen and lumpy. And then swollen nodes that are, and they're saying, basically what they're saying is swollen nodes that are not necessarily near the primary tumor here, that would be an N3. And then metastases, easy, M0, no mets, and M1, yes, we have mets. So it's, I mean, it's mostly just doctors using that grading system. The prevention, this stuff makes sense. I'm not gonna, you guys can go over that stuff. Section. This is all just make sure you do your self-exams. You should know these 7 warning signs of cancer for your tests. So unusual bleeding or discharge, and that can be not just like vaginal bleeding, like breast nipple discharge. There's all kinds of different areas. A lump that's thickening in the breast or otherwise, a sore throat that doesn't heal, a change in bowel or bladder habits, persistent hoarseness or cough, persistent indigestion or difficulty swallowing, and then a change in a wart or mole. So make sure you have these guys memorized for the test, or just, I mean, they kind of make sense anyway. This is kind of nursey stuff about how the patient feels during a diagnosis and how we have to have a plan and a physical exam and specific studies, but you guys will figure that stuff. That's not, and there's no explanation necessary, I think, there. So this is talking about how the patient's environment can affect that cancer, or can yeah, and so for example, in breast cancer, if you carry the BRCA or BRCA1 or BRCA2 gene, that makes you much likelier. You're much likelier to have breast cancer. You know, whether you're taking exogenous hormones, so estrogen, progesterone, testosterone. If you have poor immune system, you're around chemical carcinogens, you're smoking or whatever, you, oh, there's a good radiation one, UV tanning beds. I should have thought of that. That's a big one, right? And then oncogenic viruses like HPV, hepatitis, and so on. So when they do a biopsy, there's 3 kinds of biopsy: a needle biopsy, an incisional, and excisional. Needle is just what it sounds like. They just stick a needle in it, pull a tiny piece of it out. Incisional is when they go in and they'll actually make an incision, and then they make an incision in the skin, they make an incision in the tumor and kind of pull a chunk of it out. And then excisional means they take out the entire tumor, and that's how they, you know, then they stage it after. Okay, so your care depends on all of that stuff: cell type, location, extent of disease, physiologic, psychological status. There's these 3 kind of types of care for cancer. You have curative therapy. This is something that, obviously, this is something we're doing that will remove the cancer from the body. So sometimes that's surgery alone. If you just, so say with my son's tumor, if they had just taken that out and there was nothing left, that's it. That's a curative therapy. Unfortunately, he had a stage 3, which if you go back, no, stage 4. If you go back, you'll see that it was actually into the lymph nodes. There was lymph involvement. And so that means they couldn't just do surgery. They had to also add chemotherapy to that. But it's still curative. It's still a curative therapy because the hope is that we're going to, I mean, they never say cure cancer, but like put the cancer into full remission, right? And then control treatment is, you know, that just the maintenance therapy. So sometimes during or after chemo, this happens a lot with breast cancers where you have to take tamoxifen or some kind of oral chemo for a while after you have a surgery or so on. And then palliation. Remember that palliative care isn't always caring for people who are dying, but palliation is when the goal or the focus of the care is on relief and control of symptoms and quality of life. Make sure you know the difference between these guys for sure. Sorry. And then, you know, it's just a bunch of words you guys, you know, just have to know. So adjuvant therapy is when they use a treatment after they've done something to rid the body. So usually adjuvant is chemo after surgery. So exactly what happened with my son. Adjuvant therapy is the chemo, right? The thing that you do after you do the initial treatment would be adjuvant. Adjuvant just means like more secondary kind of. And then neoadjuvant is basically the first thing that you do, and it's usually it's a preoperative chemo. So sometimes they'll have a patient go on chemo to shrink the tumor a little bit, and then they go and do surgery. But just make sure you understand the difference between those two. I don't want to like, there's things you guys can read through on your own. There's tons of information on these slides. This is a picture of a radiation therapy. So really important to know that, so they're really, really careful about where, first of all, the radiation beam usually isn't quite that big. Well, I guess depending, but you don't need to understand how radiation therapy works. You know, it produces ionized excitation. It breaks, I mean, maybe knowing that it breaks the bonds in the DNA, that could definitely come up. Like that's its main thing in terms of fighting cancer. It breaks the bonds in the DNA, which causes it to stop proliferating. And then hopefully the normal tissues are able to recover. But I think there's a slide that shows you a couple of other things. Fatigue is a big thing with nursing. I'm not going to go through these because we weren't even supposed to talk through this week, right? So I know you guys can read through that stuff. You remember that anorexia is a huge side effect of mostly of chemo. So we have to watch and make sure the patients are eating, probably give them supplements. Skin reactions, this is talking about skin reactions usually after radiation. So you have this very dry skin. You could have, well, really dry or wet reaction. I think there's a slide that showed the difference somewhere. So make sure you know that the dry skin should be lubricated, but with non-irritating lotion, no metal or alcoholic perfume or additives. And then that wet reaction should be kept clean and protected. So we're not putting anything on, like in terms of creams and stuff, but we're going to probably put some gauze on it, right? So just kind of make sure you know the difference between those two. Everything else you guys can read. So this is a big thing. Patients who are on chemotherapy often get it has a major effect on the inside of their mouth. So a lot of cankers, a lot of sores on the inside of their mouth. And you can imagine, like, if you're already suffering from anorexia, and now every time you eat it hurts, you know, it just kind of makes everything worse. Oops, sorry. So anyway, this is a really good test question that can come up. Just make sure you understand that happens. Make sure the patients examine their oral cavity every day. Make sure they're if they have any major dental work that needs to be done, it has to be done before they start radiation or chemo. And then sometimes you might need to use saliva substitutes, and obviously good oral care. These are really, yeah. So if you had a select all that apply, make sure you click on oral care or something that has to do with that. Okay, so we're taking pain relief, frequent feedings, avoidance of extreme. This stuff you guys can read through. And then, oh, I think this is one of the last slides. So ondansetron, it's huge. Patients who are on chemo have a lot of nausea and vomiting. And ondansetron seems to be kind of the first line antiemetic that we use. So that's really the only really important thing to know about that. So chemotherapy, the goal is to reduce the number of cancer cells in the tumor site. Obviously there's it's going to depend on a million different factors, right? And yeah, and some of the cells will be still in that G0 phase. Remember I said they lie dormant and they don't necessarily begin to go into that interphase. If they're in that G0 phase when you get chemotherapy, sometimes they will survive the chemotherapy, and that's why cancers, part of the reason anyway, that cancers will return after you've had treatment and you're cleared, but then it can come back. In fact, they will check. I know they checked with my son up to 5 years. They checked him every 3 months because of this. And there are certain, drug-resistant, non-cycling cells, and that really has to do with that G0 phase. So if you know that, I think you'll be fine. Just understand that chemotherapy isn't only IV. You can do it, there are pills that you can take, or even liquids. You can do it IM. Intracavitary is when they basically put the chemotherapy into the space where the tumor was. So like the cavity where the tumor was. So the intracavitary. Intrathecal is in the spine, right? The thecal space is the space between the lamina or whatever in the spine. And then intra-arterial, that makes sense. You can understand that. This you guys can remember on your own. Okay, so this is where, so if the chemotherapy can't necessarily tell the difference between a cancer cell and another rapidly dividing cell in the body. So remember I said that hair cells divide rapidly, certain skin cells divide all your skin cells develop rapidly. The inner lining of your GI system, that divides very, very rapidly. So this is why people lose their hair on chemotherapy. The chemo can't tell the difference, right, between those cells and the hair cells. Typically, the hair, skin, and GI cells need about a week to replenish. So what they do is they give pulse chemo, meaning they give chemo once and then they wait a week and then give chemo. Do you know what I mean? Give chemo again. They never give like a whole dose and then just walk away, right? It's always like a treatment over time. That's not the only reason they do that, but that's part of the reason. Make sure you know about the taste alterations. That's a big one. So we already know that it's going to cause, chemo is going to cause nausea, vomiting, hair loss, maybe skin abrasions, problems with the GI tract. But then it's also going to cause fatigue and anorexia. Those are huge, huge side effects. And that's why a lot of people will have a prescription for marijuana during chemo. It deals with the nausea and it also gives them an appetite. And then taste alterations is a big one. So something that you liked before chemo will suddenly, the taste of it completely changes. I know that, so when my son was on chemo, all of this stuff happened. He lost his hair, even eyebrows. eyelashes, everything is gone. And then, yes, very tired, not wanting to eat, but then anything that I would give him that he normally loved, he would just spit it out. And the only thing he would eat were hot dogs, just hot dogs, hot dogs, hot dogs, hot dogs. It was disgusting. I don't know how he still likes hot dogs, but sometimes it's just whatever your body will take. You know what I mean? You have to eat. So if it's hot dogs and pizza, it's hot dogs and pizza. This is pretty much telling you, so you're a chemo, obviously it's a very, very toxic substance. And so we need to be careful how much we're giving. So if, a sign of a toxicity would be these things on the left, and then delayed effects, these are things that are going to happen kind of later on during the pulse. So if you give chemo on a Monday, you might see 3 or 4 days later, or a week later, or 2 weeks later, some of these delayed things happening. But on usually the vomiting, allergic reactions, arrhythmias, those things will happen right away or very, very soon after giving the chemo. Know that chemotherapy drugs have long-term effects on your heart, kidney, liver, and lungs. So I have a 14-year-old who has to get an echocardiogram every year, right? Because he had so much chemo in his body. They have to check for long-term effects, and they'll keep checking until he's like in his 40s. Okay, yes, the drugs are usually given in combination. So you will go and have your doxorubicin one day, and the next you might have 2 weeks later, you might have your dactynomycin, and then they go back and forth. I don't know how they decide how or when to give what, but it's always not always, usually in combination according to body weight. I'm not going to go through this. You guys can read that. Oh, you should know what that nadir is. So, sorry. This is just talk. Yeah, that's fine. So, yes, for us, for nurses, we're giving the antiemetic drugs. We're monitoring lab results, particularly white blood cells and platelets and red blood cells. So, chemotherapy drugs drop your white blood cell counts. Often your platelets and red blood cells too, but the white blood cells really, really drop. And so, do you remember when we talked about inflammation and we talked about neutrophils and those neutrophil bands? So because of the effect of chemotherapy on white blood cells, the patients who are on them have to get their blood work done all the time, sometimes twice a week, sometimes once a week. And they are monitored very, very carefully for any kind of neutropenia or low leukocytopenia at all. And then oftentimes, for example, if we went in and he was neutropenic, in other words, his neutrophil count was very low, the next dose of chemo might be held off for a week, or they might give him a half dose, right? So they kind of play around with it depending on the side effects. And yes, so we're watching platelet count and RBCs, so watch for signs of bleeding. Make sure you don't miss that if it shows up on a test. And then this is important to know. This nadir is the time after chemo when the white blood cell count and platelet count is at its lowest point. So it happens usually, for us, it happened about 9 days after chemo, where where the white cell count was down so low that you're very, very susceptible to infection.